Welcome to the deep dive. Today we're digging into something quite fascinating, a often hidden reason behind a lot of chronic shoulder and neck pain. You know, the kind that affects so many people, from elite athletes right through to those of us spending hours at a desk, perhaps maybe even you.
hmm
We're talking about scapular dyskinesis. Basically, when your shoulder blade doesn't move quite right. It's often overlooked, but it's this really critical link between your shoulder and your spine. It impacts, well, both how you move and how stable you are.
Absolutely.
So our aim today is to really unpack this clinical puzzle. We'll look at the basic anatomy, why it matters, why it's sometimes missed in diagnosis, and crucially, the science-backed ways to manage it all tailored for our clinical audience. And I'm delighted to be joined by our expert, known for making complex orthopedics clear and relevant to patient care.
It's great to be here. It's such a vital topic. And you're right, often underappreciated in musculoskeletal health.
Couldn't agree more. So let's start right at the beginning. How would you actually define scapular dyskinesis? And what do people mean when they talked about shoulder blade winging?
Okay. Well, scapular dyskinesis at its core is simply an abnormal position or motion the shoulder blade when the shoulder moves. And winging, yeah, that's the common term for when the scapula sticks out noticeably from the back, either when the arm's just resting or during movement.
Right.
But what's really key here, I think, is understanding just how crucial the scapula is. It's not just sort of floating there. It's a really integral part of the whole upper limb kinematic chain. It acts as the center of rotation for the humerus, your upper arm bone, and it provides a stable anchor to the thoracic wall, your rib cage.
That anchoring role sounds, well, fundamental. It's clearly much more than just a simple bone, then. It sounds like understanding its roles changes how we should think about shoulder mechanics, doesn't it? Maybe even challenges some older ideas.
It really does. You see, the scapula has four absolutely essential biomechanical jobs. First, it's the main center of rotation for the humerus, allowing that huge range of motion we have in our arms. Without its precise movement, your arm just can't move properly.
Okay.
Second, it acts as that stable anchor for the humerus onto the chest wall. That stability is vital for generating power and maintaining control, particularly in dynamic things like throwing or lifting.
Right.
Third, it's crucial for preventing impingement. It ensures the acromile, that bony bit at the top of the shoulder blade, doesn't sort of block the humeral head when you lift your arm overhead.
I
And
see.
finally, it's a key link for transferring forces efficiently, right from your body's core, through the arm and out to the hand. It's a critical part of that whole kinetic chain.
That's quite a list of responsibilities. Now, thinking about normal shoulder movement, many of us learned about the traditional 2.1 scapulohumeral rhythm. How has our understanding of that sort of classic model changed? Is it still the go-to, or is it a bit more nuanced now?
That's a really good point. The scapula actually has this incredibly complex range of normal movements:
Yeah.
elevation, depression, protraction, retraction, rotations at different planes, tilting.
Mm-hmm.
It's quite intricate.
Mm-hmm.
And while that traditional 2.1 idea, 2 degrees of arm movement for every 1 degree of scapular rotation, was a useful starting point, uh, more recent research definitely shows a much more complex picture. It's actually quite variable.
Variable. How so?
Well, the pattern really depends quite heavily on the specific movement you're doing.
Mm.
It highlights just how dynamic and adaptable the whole shoulder complex is and why sticking rigidly to that 2.1 rule often doesn't quite capture what's happening in a real clinical situation.
Okay, that makes sense. So given its critical and, as you say, dynamic role, it's not surprising that if things go wrong, it can cause widespread problems. Who are we typically seeing affected by scapular dyskinesis? Is it mainly athletes or desk workers or...
It's definitely a mix, and that's crucial for clinicians to grasp. Chronic neck and shoulder pain are incredibly common, affecting, what, over 60% of people at some point? And scapular dyskinesis is very often found in these patients, often alongside muscle weakness and shoulder instability.
Right.
We see it a lot in athletes, no question.
Oh.
Particularly overhead athletes, think baseball pitchers, tennis players, swimmers, volleyball players, gymnasts. Some studies show prevalence as high as 54.5% in overhead athletes.
Wow, that high.
Yes, and interestingly, even athletes without symptoms but with dyskinesis have a significantly higher risk, around 43% greater risk of developing shoulder pain down the line. Think about that tiny loss of control in a serve or a swimmer's slight niggle. It often starts here.
So it can be predictive almost.
In a way, yes, but it's not just athletes. Computer users are another really big group. That prolonged sitting posture can really alter how the scapula sits and moves over time, Also, some data suggests young men, maybe 18 to 25, are particularly susceptible, and it often affects the dominant arm, probably due to that repetitive uneven loading.
So it's clearly more complex than just that obvious winning. And given how widespread it is and how subtle it can be, what's really causing these movement problems? Is it always an injury, or are there other underlying factors clinicians should be looking out for?
It's almost always multifactorial. That's why a thorough assessment is just so important. We can generally group the causes into a few main areas. Firstly, and probably most common, are muscle imbalances and performance deficits.
Okay.
Think of it like this. Your upper trapezius, the muscle that gets tight when you're stressed starts working overtime, while key stabilizers like the serratus anterior and lower trapezius get a bit lazy or weak.
Great. The balance is off.
Exactly. It's not just an imbalance in strength, it disrupts the timing and coordination. It's like trying to steer a car with loose steering and sticky brakes. It really messes up the smooth motion in the shoulder blade, creates these force imbalances.
Okay, so muscle issues are key. What else contributes?
Well, secondly, there's a lack of soft tissue flexibility. If muscles like the pectoralis minor at the front of your chest are tight, or the capsule at the back of the shoulder is stiff, they can physically pull the scapula out of its optimal position, things like increased internal rotation or anterior tilting. Addressing posterior shoulder tightness, for example, often helps resolve impingement symptoms.
Makes sense. It's being pulled out of place.
Precisely. Thirdly, we sometimes see neurological injuries. Damage to specific nerves can directly cause dyskinesis. The classic example is damage to the long thoracic nerve affecting the serratus anterior that causes really prominent winging, or damage to the spinal accessory nerve affecting the trapezius, which can lead to the scapula drooping.
Okay, direct nerve involvement.
Yes. Then, fourthly, there are associated shoulder pathologies. Scapular dyskinesis very often goes hand in hand with almost all common shoulder problems. We see it frequently with shoulder impingement, often with more scapular protraction and altered tilt. Also with rotator cuff injuries, where you get strength loss and specific dyskinesis patterns. It's strongly linked to glenohumeral instability, labral tears, AC joint injuries, even clavicle fractures. The disturbance in the scapulohumeral rhythm is often part of the problem, or makes it worse.
So it's often a fellow traveler with other shoulder issues.
Very much so. And finally, don't forget neck and posture-related issues and overuse. There's a really close link between neck pain, whether it's mechanical or nerve-related, and scapular function. Poor posture, like that slumped posture with increased neck and upper back curves, directly affects how the scapula sits and works. And of course, repetitive overhead activities, common in sports, can lead to overuse injuries that disrupt normal scapular motion over time.
That's an incredibly thorough breakdown. It really highlights how interconnected everything in the upper body is. Thinking about all those factors, is there one clinicians perhaps most often overlook? Or maybe one where focusing attention could yield really significant improvements for patients? Perhaps back to those muscle imbalances.
That's a really insightful question. I think perhaps the most underemphasized factor is how much global posture influences the scapula. It's quite easy to get hyper-focused just on this shoulder joint itself, isn't it?
Yeah.
But that slouched posture, the increased thoracic kyphosis, that curve in the upper back we see in so many people, especially office workers, or even just subtle neck pain, it directly impacts where the scapula rests and how freely it can move. Sometimes a relatively small correction in posture can have this fantastic positive cascade effect on shoulder function. The clinicians might jump straight to shoulder exercises, but the primary driver might actually be more central, more proximal.
That's a fantastic clinical pearl, especially for primary care. So, given this complexity, how do clinicians actually identify scapular dyskinesis, especially if it's subtle? What does a practical assessment involve?
Right. Well, the diagnosis is mostly clinical. It relies heavily on a really good physical examination. We generally don't need routine x-rays or MRIs just for the dyskinesis itself, though obviously we'd use them if we suspect related bone or significant soft tissue injuries.
Okay.
We usually approach it in three main stages. First is direct observation. This is absolutely fundamental. We watch the patient carefully how their scapula sits at rest, and crucially how it moves during active movements like lifting the arm forward, flexion, or out to the side, abduction. We're looking for that obvious winging, sure, but also subtler things. Does the scapula elevate too early? Does it rotate downwards too quickly or in an uncontrolled way? It's about spotting those deviations from smooth, coordinated movement.
So a keen eye is key.
Definitely. The second stage involves manually assisted movements. These tests can be incredibly revealing, things like the Scapular Assistance Test, or SAT. Here, the clinician gently helps the scapula move into upward rotation and posterior tilt as the patient raises their arm. If doing that reduces their pain or increases their range of motion, it strongly points towards the scapular dysfunction being a key part of their symptoms.
Oh, okay. That makes sense.
Another really useful one is the scapular retraction test, or SRT. We manually stabilize the scapula, holding it in a more retracted position. If this improves the patient's strength, maybe their rotator cuff strength test feels stronger or reduces their pain, it tells us the scapula wasn't providing that stable base it needed to. We might also use tests like the lateral scapular slide test, or look at muscle endurance with things like an isometric scapular pinch or wall push-ups.
Got it. And the third stage?
The third stage, linking back to our earlier point, is the assessment of surrounding structures. It's absolutely vital to examine adjacent areas, the thoracic spine, the AC joint, the clavicle, and definitely the rotator cuff, for any contributing factors that might be driving or influencing that scapular dysfunction. It's about looking at the whole picture.
So it's very much a hands-on observational process, using specific tests to see how changing the scapula's position or movement affects symptoms or function. But I gather there are still some limitations, especially in getting really precise measurements. It feels like there could be a degree of subjectivity.
You're absolutely right. The sheer complexity of 3D scapular motion makes truly quantitative assessment in the clinic quite challenging with the tools we typically have available. It's hard to measure those subtle rotations and tilts precisely and reliably. Because of that, there's a growing trend towards using more holistic, system-based approaches. Something like the shoulder symptom modification procedure, the SSMP. This involves systematically testing different manual corrections like altering scapular position or thoracic posture to see which specific modification most improves the patient's main complaint, like pain during a specific movement. It helps identify the key contributing factors for that individual.
That sounds very practical.
It is, and looking forward, I think we'll see exciting developments. Things like AI combined with 3D motion capture technology hold real promise for giving us more objective, reliable ways to measure scapular motion in the clinic. That could be a real game changer for both research and day-to-day practice.
Fascinating to think how technology might refine diagnosis. So once scapular dyskinesis is identified, what are the main rehabilitation strategies? What's the gold standard? And importantly, how do you tailor treatment for, say, an office worker compared to an elite athlete?
Yeah, the gold standard is definitely conservative management, physical therapy, and rehabilitation. Surgery isn't typically for the dyskinesis itself, but rather for any associated problems like a rotator cuff tear that needs repairing.
Right.
And you've hit the nail on the head, treatment must be tailored. The functional demands, and therefore the rehab goals, for an office worker who mostly needs good scapular control during prolonged sitting are vastly different from an elite overhead athlete who needs advanced muscle control and strength for very specific high-speed, high-load movements.
Okay, so how do you approach that? What are the main targets?
We generally focus on two main areas. First is rehabilitating flexibility deficits. This means using specific stretches and mobilization techniques to get back optimal muscle length and joint movement around the shoulder girdle. Good examples are things like the unilateral corner stretch for a tight pec minor, or the sleeper stretch or crossbody stretch for stiffness in the posterior capsule. These help the scapula sit and move more freely.
Makes sense, creating the potential for good movement first.
Exactly. Then the second, and often the bigger part, is rehabilitating muscle performance deficits. This is usually done progressively, often in 3 stages. Stage 1 is about conscious muscle control. The main goal here is improving proprioception, that awareness of where the scapula is, and teaching the patient how to normalize its resting position. Exercises like the scapular orientation exercises are great for selectively activating the lower trapezius without hiking the shoulder. We also really emphasize integrating spinal posture correction, like a simple occipital lift to lengthen the neck, and sometimes use therapeutic tape for extra feedback. It's about re-educating the neuromuscular system, building that foundation of awareness and basic control.
Okay, building the brain-muscle connection.
Precisely. Stage 2 then focuses on muscle control and strength for daily activities. Here, we start training muscles to work together, co-contraction, and address strength weaknesses, particularly in the serratus anterior and the middle and lower trapezius. This involves both open chain exercises like low rows or lawnmower pulls to work the retractors, and closed chain exercises like push-up variations or wall slides, which demand more stability. We focus on exercises that promote good muscle balance, getting that lower trap working well relative to the upper trap, and start integrating the kinetic chain. For instance, adding a leg extension during a push-up can actually boost serratus anterior activity by linking into core stability.
Interesting how you integrate the whole body.
Yes, it's crucial. Then, stage 3 is about advanced control during sports movements. This is where we really ramp things up for athletes or highly active individuals. We transition to very sport-specific drills, often incorporating plyometrics, explosive exercises, and eccentric loading, which is strengthening the muscle as it lengthens under tension. This builds power and resilience. It's all about integrating the entire kinetic chain for advanced control and strength that mimics the demands of their actual sport. So for a thrower, it might be eccentric external rotation exercises to control the deceleration phase. For a swimmer, maybe exercises like the WV on a Swiss ball, demanding core and scapular stability during arm movements that simulate strokes.
That phased approach makes so much sense, building the foundation before adding complexity and load. Are there common stumbling blocks clinicians should watch out for at each stage? Things patients often struggle with.
Oh, absolutely. In stage 1, a very common pitfall is patients compensating. They tend to overuse their upper traps or just shrug their whole shoulder instead of isolating those lower scapular muscles like the lower trap or serratus. It requires really precise cueing and often tactile feedback from the therapist.
Right, getting the activation right.
Exactly. In stage 2, a challenge is often patients wanting to add too much weight or resistance before they've truly mastered the movement pattern and motor control. Form really has to come before load. Poor form under load just reinforces bad habits.
Good point.
And in stage 3, probably the biggest pitfall is athletes returning to their sport too soon. They might feel strong in the clinic, but they haven't fully integrated those new efficient movement patterns under conditions of fatigue or sport-specific stress. That's often when re-injury happens. Consistent reinforcement is key.
Excellent practical tips there. So, thinking about that return to sport, what about specific criteria? Are there clear guidelines? And perhaps most importantly, what's the evidence backing up these rehab strategies? Why should we be confident this approach works?
That's the crucial question, isn't it? Regarding return to play, or RTP, there aren't really rigid, universally standardized guidelines that apply to every sport, unfortunately. So clinicians tend to rely on a combination of factors.
Okay.
Key clinical criteria usually include things like minimal or no pain during sport-specific activities, the patient feeling subjectively confident and satisfied with their recovery, achieving near-normal range of motion, and restoring strength. For strength, we might look for symmetry between limbs in non-throwing sports, or perhaps aim for the dominant side in overhead athletes to be about 10% stronger than the non-dominant side. Passing specific functional fatigue tests relevant to their sport is also important. And, crucially, we always advocate for ongoing prevented exercise programs even after they're back playing to minimize the risk of it happening again.
Right. Maintenance is key, and the evidence.
The evidence supporting these scapula-focused rehab strategies is actually quite robust now. Numerous clinical studies have shown that well-designed scapular training programs lead to significant gains in, for instance, isokinetic scapular muscle strength. They also improve the function of related glenohumeral muscles, like strengthening the infraspinatus in volleyball players. We also see clear benefits for specific conditions. Studies on overhead athletes who have impingement symptoms consistently show that scapula-based exercises improve muscle recruitment patterns. Importantly, they often decrease that overactive upper trapezius firing and lead to significant improvements in function and reductions in pain.
That's encouraging.
Absolutely. And randomized controlled trials, the gold standard, really confirm that adding specific scapular exercises into rehab programs for shoulder impingement results in better functional outcomes, better strength gains, and higher patient satisfaction compared to more general shoulder rehab alone. What's also interesting, linking back to the neck, is evidence suggesting that scapulothoracic mobilization combined with physical therapy might actually be better than just physical therapy alone for mechanical neck pain. Studies have shown reductions in neck pain and even improvements in grip strength with this combined approach. We've also seen case series where focused rehabilitation successfully resolves scapular dyskinesis and improved function even in patients with chronic AC joint dislocations.
So, quite compelling evidence across different conditions.
Yes. So while the evidence strongly supports using therapeutic exercise for scapular dyskinesis itself and shows that positively impacts related conditions like impingement and instability, research is, of course, always ongoing. We're still working to pin down precisely how much direct influence correcting dyskinesis has on reducing primary shoulder and neck pain versus improving overall function. but the picture's becoming increasingly clear that it's a critical piece of the puzzle.
This has been an absolutely fascinating deep dive. It really drives home the huge impact of properly understanding and addressing scapular dyskinesis, right from getting the diagnosis accurate through to that tailored evidence-based rehabilitation. It's clearly such a pivotal area in musculoskeletal health, something all of us in the medical field really need to be aware of.
I agree completely. Paying attention to the scapula, its position, and its movement is just crucial for anyone managing patients with upper limb or neck complaints.
Definitely. As we wrap up, perhaps a final thought for our listeners to mull over. Given that scapular dyskinesis can, as you mentioned, exist even in people without symptoms, what might that mean for potentially screening high-risk groups more proactively? Could intervening earlier fundamentally change long-term outcomes for these patients? If you found this deep dive valuable, please do consider leaving us a rating or sharing it with a colleague. Thank you so much once again for sharing your expertise and insights with us today. It's been incredibly valuable.
My pleasure. Thanks for having me.